Good evening and welcome to this update on diagnosis of respiratory infection organized by the Pan-African Thoracic Society in conjunction with Biomerics. We have an interesting lot of speakers today, and let me first take this opportunity to thank first Biomerics for sponsoring this webinar and Gombile for organizing the webinar. Let me also thank the speakers who have agreed to participate to the evening, and finally, all the participants who have already logged in. You're most welcome. Our topics will be three. We're going to discuss overview and challenge your diagnosis of respiratory infection in adults by Bertrand Bachu, followed by respiratory diagnosis of respiratory tract infection in children by Dr. Mlemo Kishin, and finally we'll end by talking about how syndromic testing is transforming the diagnosis of respiratory illness by Dr. Kiplagat Sige. My name is Dr. Alwaj. I'm the chairman or the president of the Pan-African Thoracic Society and the chairman of today's meeting. And I just start by making a few remarks regarding pulmonary infection, and particularly as regards the challenges that faces management of respiratory infection in sub-Saharan Africa. Respiratory tract infection involves respiratory tract in two parts, the upper respiratory tract and the lower respiratory tract. It's the most common type of infection which is probably encountered in a medical practice, particularly in an adult. It is estimated that at least 2 to 4 episodes of respiratory infection is experienced by each adult annually. The lower respiratory tracts are less common, but the most common cause of death and hospital admission all over the world. The mortality of this infection in the world is estimated to be over 75 million. They are characterized by acute febrile illness, which may present with residual cough or coryza or sore throat hoarseness, and this forms the prime reason for affecting by upper respiratory tract infection. Majority of the upper respiratory tract infections really are benign, and the exact etiology often is not known and poorly understood. And quite often it's not necessary to prescribe antibiotics as often done by some clinicians. The lower tract infections have more severe symptoms with cough, chest pain, and often difficulty in breathing. In Africa, the highest deaths from respiratory tract infections can be seen particularly in children. 20% to 30% of hospital consultation or admission can be attributed to a respiratory tract infection, which is more or less the same as developed country. Now, there are several risk factors which we'll discuss in detail shortly. So this include various malnutrition, air pollution, smoking, overcrowding, as we shall refer to shortly. Like all health problems, you can divide them into three: the host factors, the agent factor, and the environmental factor. Most of the infections are caused by bacteria and viruses in the respiratory tract infection, which may manifest as influenza, sinusitis, otitis, nasopharyngitis, tonsillitis, and bronchitis, and pneumonia. Listed here are some of the common bacteria: Strep pneumoniae, all leading, and Staph aureus, Strep pyogenes, Mycobacteria TB, one of them, Pseudomonas, Haemophilus, and Klebsiella pneumoniae. The fungi, Aspergilla niger, is probably a significant one. But the viruses are mainly rhino, coronavirus, adenovirus, influenza virus, respiratory sensitive virus, and para-influenza viruses, and EB viruses are all viral. The whole host factors are very prominent, particularly in sub-Saharan Africa, because the infants often have low birth weight, And once infected, they're more likely to die. Hence, one of the common causes of infant mortality in sub-Saharan Africa is from pneumonia. Malnutrition also significantly lower the resistance of the child from infection and often give you grave consequences because it interferes with the mechanical structure of the respiratory tract, which may end up not being efficient in warding off any bacteria or that matter virus infection. Lack of immunization is a common complication, which may be associated with measles, whooping cough, and can be prevented by appropriate immunization with measles, whooping cough, and now we also have the pneumonia vaccination, which is still low coverage in most of Africa. Immune status, this is particularly in adults with HIV or organ transplant or some congenital or long-term still use as cancer, may also predispose to respiratory tract infection. Environmental factors, we also see air pollution, indoor and both outdoor, directly associated with increased respiratory tract infection. As we know, the pollution may interfere with the ciliary activity. As you know, ciliary system is responsible for clearing the scavenger system of the respiratory tract to remove unwanted matter from the respiratory tract, which may also result in infection. Air pollution is very common in Africa, particularly indoor, from whatever used for cooking and heating fires. It may predispose residents, and even children are exposed to this in the smoke as early age as their mother cook and holding them using some of the biomass fuels, charcoal. Smoking also releases a lot of chemicals that we know very well and has been well studied as affecting the respiratory tract and predisposing to frequent infection, whether active or passive. Overcrowding also common in sub-Saharan Africa, particularly in the slums with poor ventilation, are all factors that predispose to infection. And finally, there are some potential risk factors associated with mortality, particularly as you work in a lot of places where there's a lot of pollution or affected by HIV high prevalence. TB still accounts for up 1/4 of respiratory tract infection in the sub-Saharan Africa, and the clinical assessment of some of the respiratory infection maybe have some constraint because of the limited access to examination facilities, including radiography or even the clinical assessment by healthcare workers. But we know that it's easy to get a lot of samples for RTI, either from throat swab or saliva or sputum, for example, TB, pleural aspirate, bronchial aspirate, nasal swab, or paranasal swab, as we are now using this, particularly in COVID pneumonia. And several available assays which can be used to identify this. Some of these, I'm sure the speakers will tell us in more detail. And finally, traditional medicine over the years have been gram stain or culture and sensitivity to McConkie or chocolate gram, or microscopic examination of weight preparation, or biochemical tests are available, but more these days we have molecular detection, including non-molecular detection, including electron microscopy, calcium, or anti-degradation assays, rapid immunoassays, direct fluorescent antibody tests, serological tests, and finally we are now using a lot of nucleic acid and fluid tests for detection and identification of respiratory agents. This includes PCR and ELISAs. They are very good, but unfortunately they may be expensive, and sometimes they may be associated with some contamination. So we still need to, develop a country where there's a lot of TB to evaluate point of care by using psychic facilities as expert for making sure that we can diagnose cause of the respiratory infection early, particularly with TB, and particularly in patients who may not produce a lot of sputum. There are other methods available, particularly in HIV, or TB, but some of these I'm sure our next speakers will be able to discuss them. And that is just a simple introduction. I thought I would introduce them today's talk about. But now let's go to the main speakers, and now it's my great pleasure to talk about the next speaker. We're going to talk about the challenge of diagnosing respiratory infections in adults, who is associate professor, that is Professor Bachu, associate professor of respiratory medicine at the University of Douala, and he's also a consultant pulmonologist at Douala General Hospital, and also the vice president of PATS is my vice president. Dr. Bachu, you now can start sharing the screen, and the floor is over to you. Thank you. You're welcome.
Thank you, Joe. Thank you, Joe. So I will start by thanking Pan-African Thoracic Society and Biomerus Laboratory for inviting me to this presentation. So I was given the presentation on overview and challenges of diagnosis of respiratory infections in Africa, infection in adults. This is the outline. So in introduction, what I will say is that respiratory tract infection is defined as any infectious diseases of the upper and lower respiratory tract. Upper respiratory tract infection includes common cold, laryngitis, pharyngitis, acute rhinitis, sinusitis, and otitis media. Going back to the lower part of the respiratory tract, we'll have lower respiratory tract infection involving bronchitis. We'll also have bronchiolitis, pneumonia, and tracheitis. In this presentation, I will mainly focus on lower respiratory tract infection. And as tuberculosis is a very focal entity, I will only focus in this presentation on community-acquired pneumonia, which refers to an acute infection of the pulmonary parenchyma acquired outside of the hospital. In opposition, we have nosocomial pneumonia, referring to pneumonia acquired in the hospital settings and comprising hospital-acquired pneumonia and ventilator-associated pneumonia. HAP refer to pneumonia acquired more than 48 hours after the admission, hospital admission, while ventilator-associated pneumonia refers to pneumonia acquired more than 2 days after endotracheal intubation. Community-acquired pneumonia are the fourth most causes of death in the world. And according to the GBD 2019, they are the second cause of loss of life. And in Africa, community-acquired pneumonia is associated with an in-hospital mortality varying from 6 to 15% among adults, as reported by some hospital-based studies. And we have about 4 million episodes of pneumonia in the continent each year, resulting in about 200,000 deaths. Pathogens constantly enter the airways, but there are different factors preventing the colonization of the respiratory tract. There are mucous, there are ciliary clearance, we have also the immune system and the epithelium, as well as some factors secreted at the level of the respiratory tract. And pneumonia occurs when there is a disrupting or overwhelming defense mechanism at that level. The different factors of the disruption of the mucociliary clearance are the airway obstruction, as we can see in chronic obstructive pulmonary disease, in chronic bronchitis, in some of neoplasm and bronchiectasis. We can also have the disruption of the mucociliary clearance during ciliary dysfunction in some of conditions like cardiogenic syndromes or in people who smoke. Concerning the disruption of the epithelia, we can have injuries like in pulmonary edema or during the intubation. We also have some viral infections that can disrupt the epithelial barrier of the respiratory tract. In the other side, we have a situation where we have an increase in the inoculation event, like during the alteration of the conscientiousness, dysphagia, intubation, and during bacteremias. We have this decreasing of immune function when you have the suppression of the immune system, like in HIV, in patients receiving chemotherapy or long-term oral steroid. What are the risk factors of CAP? Different factors are known, like extreme age. We can have children less than 5, and in the other side, people age more than 65 years. We have chronic conditions like COPD, heart failure, chronic lung diseases. We have stroke, diabetes mellitus, and immunocompromising diseases. We also have impaired airway protections when the consciousness is not good, or dysphagia. The other risk factors are smoking, alcohol overuse, air pollution, and especially indoor air pollution in our continent. We have other lifestyle factors like living in crowded conditions on some of the environmental toxins. Coming to the clinical presentation of pneumonia, we have two presentations which are typical, and the second one which is atypical presentation. The term typical presentation, typical CAP, refers to a bacterial pneumonia caused by pathogens such as Streptococcus pneumoniae, Haemophilus influenzae, or Moraxella catarrhalis. And they usually present with fever, cough with purulent sputum, dyspnea, pleuritic chest pain, and the signs are tachypnea. And when we examine the lungs of the patient, we may have signs of lung consolidation. The most common bacterial pathogen is Streptococcus pneumoniae, and we may see Haemophilus influenzae or Moraxella catarrhalis when you have underlying conditions like COPD. When we have a patient with a recent influenza infection, we may have other pathogens like Staphylococcus aureus or Streptococcus pneumonia. When in alcoholic patient, the pathogens like Klebsiella pneumoniae is more frequent. The atypical presentation of pneumonia is usually not abrupt. It's usually subacute and frequently indolent. And patients with this atypical CAP present with more subtle pulmonary findings. What are the pathogens involved? We have bacteria, intracellular bacteria like Mycoplasma, Chlamydophila pneumoniae, and Legionella pneumophila. We also have respiratory viruses like influenza A and B, rhinovirus, respiratory syncytial virus, adenovirus, and coronavirus like the one ongoing worldwide. Some other bacteria are involved, as well as fungi like Histoplasma capsulatum, Cryptococcus neoformans, and Coccidioides. In atypical pneumonia, we can have extrapulmonary signs and symptoms, which include mental confusion, headache, muscle pain, ear pain, abdominal pain. We can have diarrhea. We could also have cutaneous rash, pharyngitis, hemoptysis, enlarged spleen, and we may also have bradycardia. After the clinical presentation, we usually need imaging for the diagnosis. And the chest X-ray is the first investigation to do. The chest X-ray can be negative when the presentation is earlier, when the patient comes earlier. And it is recommended to repeat the chest X-ray within the 24 hours. In the typical community-acquired pneumonia, we have predominantly focal opacities, like here in the upper lobe. We may also have a pleural effusion under the opacity of the lung. When it is atypical pneumonia, we have a variable radiographic finding. We can have a focal localization of the pneumonia, like here. We may also, and it's very often, we have bilateral opacities in the both lungs, like in these two chest radiographs. When it is viral pneumonia, we may have few or no infiltrate on chest radiograph, but when infiltrate are present, they are always bilateral, as shown in this chest X-ray. They are interstitial and they are usually symmetric. The CT scan of the chest has a role, especially when we have clinical signs of pneumonia and the chest X-ray is normal. It is also important and helpful to examine for the structural lung disease or when there is an underlying malignancy. I've presented here some of the chest X-ray of COVID-19 currently ongoing worldwide. And we have heard that we know that the CT scan has come to be very sensitive for the diagnosis of COVID-19. As we can see in this chest X-ray, we have multifocal opacities, ground glass opacities, and even cruising paving pattern at the level of peripheral of the lungs. What are the lab tests that we can perform for the diagnosis of community-acquired pneumonia? We can have the gram stain of the sputum. We can also have blood cultures. We have polymerase chain reaction, where we can have oropharyngeal swab. We also have urinary antigen testing for pathogens like Legionella pneumophila or Streptococcus pneumoniae. Molecular assay for influenza with the nasopharyngeal swab. We can also have serologic studies for intracellular pathogens like Mycoplasma or chlamydia. In some situations where we have persistence of symptoms, when the patient is taking antibiotic adequately, we can perform bronchoscopy and do bronchial aspiration or bronchoalveolar lavage or protected brush specimen to take specimen for bacteriological analysis. Some other lab tests are full blood count, C-reactive protein, which is usually raised in these situations. We can test for procalcitonin, and other tests are also important to see different complications of the pneumonia. I'm presenting here the role of the procalcitonin as a marker of pneumonia. And in this study done in 5 hospitals in US, they included patients with clinical signs of pneumonia and patients with signs of acute respiratory illness with radiological evidence of pneumonia. They included 645 patients with microbiologically confirmed pneumonia. And you can see here that we had 24% of viral pneumonia, 4% of atypical bacteria, and 10% of typical bacteria. So they tested for procalcitonin in this study. What did they find? They found that the median procalcitonin concentration was lower in viral pneumonia than in atypical or typical bacteria. We can see here that there was a statistical significance when they were comparing typical bacteria to viral pneumonia. As shown in this ROC curve, procalcitonin discriminated bacterial pathogen, including typical and atypical bacteria from viral pathogens with an area under the curve of 0.73. A procalcitonin threshold of 0.1 resulted in a sensitivity of 80.9% and a specificity of 51% for identification of any bacterial pathogen. We can see that when we go for a threshold of 0.25, we have a reduced sensitivity and specificity, as well as for the threshold of 0.5. So no procalcitonin threshold perfectly discriminated between viral and bacterial pathogens, but we could see that higher procalcitonin strongly correlated with increased probability of bacterial pathogen, particularly typical bacteria. In this review published in the Lancet in 2018, they saw that the sensitivity of procalcitonin to detect bacterial infection ranges from 38% to 91%. And finally, we could see from recommendation of EIDSR and ATS that procalcitonin alone cannot be used to justify withholding antibiotics from patients with CAP. What are the signs of severity of CAP? These criteria are designed by ATS and IDSA with different minor criteria, respiratory rate, the ratio PaO2 on FiO2 less than 250. We have multilobular infiltrate confusion, uremia, leukopenia, hypothermia, hypotension, and we have major criteria like septic shock or respiratory failure. The presence of one major criteria can define the severity, as well as the 3 or more minor criteria. This is the pneumonia severity score published by FINE, defining the pulmonary severity index, which is a little bit detailed with different items like comorbidity, examination, investigations, and their prognosis score. We can see that for a patient with a score more than 130, we have a high rate of mortality. Almost 3 patients on 10 have died within the month of the disease. We can also see that in patients with less than 70 of score, the mortality is very low. More practical, we have the CURB 55 score designed by the British Thoracic Society with the different items: confusion, urea, respiratory rate, blood pressure, and 65 years, 1 point for each item. And we can see that for a score of 0 to 1, we have a patient to be treated at home. With an intermediate score of 2, patients are likely to need admission when a score of 3 to 5, we should admit patient in the hospital. The CRB 65 score is easier than the previous one because here we don't need urea. We can practice it in all settings in Africa. We have 3 categories of score: 0, where we can treat patient at home; 1 or 2, we have patient likely need to hospital assessment. When it's score more than 3, is for urgent admission. So to conclude this presentation, I would say that lower respiratory tract infection are among the first common cause of death in Africa. Diagnosis is easily made based on symptoms and signs. Laboratory tests may be useful and are needed to identify the pathogens involved. And finally, CRB65 and CURB65 score are simple tools to know whether the patient should be treated as an outpatient or should be admitted in the hospital. Thank you.
Thank you, Bertrand, for excellent presentation, very thorough, very detailed, and I'm sure most of the participants may not have many questions because it's very good. I think we will reserve further discussions at the end of that 3 presentations. And now we move from the adults to a little smaller human beings, pediatrics, for which we're going to have presentation by Dr. Omolemo Kitchen, who is a pediatric pulmonologist and consultant lecturer at University of Pretoria, Department of Pediatrics previously. Currently is on private practice. His interest is asthma and allergy, and he's in practice in Midland, and he's got a lot of papers and honors to his name, but he's a prominent son of Africa to talk to us about laboratory diagnosis of respiratory tract infections in children, the state of the art. He's well positioned to do that state of the art. Dr.
Good evening, ladies and gentlemen. And I'd like to thank Pat for inviting me to do the talk. And also like to thank Prof. Masekela and the sponsors for inviting me to do the talk. I've been given the task in a few minutes to just chat to you about laboratory diagnosis of respiratory tract infection in children. Just to put things out of the way, conflict of interests, I've got nothing to declare. And this is the outline of the talk. Even though the topic has been laboratory diagnosis, I think in pediatrics it's important to go through a few factors, which includes definition, risk factors, what COVID-19 has done to children, and some other forms of diagnosis other than laboratory diagnosis, and cost, and we'll summarize and conclude. We all know that on the 12th of November 2020, the Forum of International Respiratory Society, of which PETS is a founding member, issued statement on the World Pneumonia Day. We all know that pneumonia is the biggest killer, with about 2.5 billion deaths and about 672,000 of them being children. Unfortunately, most of these deaths occur in low and middle income countries. Now, COVID-19 has unfortunately also put the spanner in the works, with a lot of statistics coming from adults, with about 1.2 million deaths and counting, out of 47 million cases globally and counting. So the first, among other objectives, one of the important objectives is to try and get a way to find a way to get support for research towards innovative diagnostic, prevention, and treatment strategies. The problem is that if you and I do nothing now, by 2030, we'll have 11 more million children die from pneumonia. Now, this cartoon is very clear that it shows lower respiratory tract infections among higher on the list of the causes of deaths globally. And these lower respiratory infections include other group 1 causes of deaths, which include maternal causes, neonatal and nutritional disorders. So what is said about this is that 50% of these conditions happen in the lower and middle income countries, which are exactly the countries that you and I work in, compared to 7% of the deaths of this group 1 causes that occur in high income countries. Now, if you look at this cartoon, that lower respiratory tract infections, which includes pneumonia, is one of the leading causes of death in low-income countries. What is important about this is that when you get statistics, it's supposed to help in trying to, firstly, it's a reflection of the healthcare system that we work in. So all these statistics is a reflection of the healthcare system that we work in. And ideally, collecting data, if it's accurate, is supposed to assist the healthcare system to plan better and try and find better ways of solving problems. Whether that's happening in our countries or not is another question. It's a topic for another day. If you look at this cartoon, it says 8.9 million children, and this is the Johns Hopkins predictive model. 8.9 million children's lives would be saved by 2030 through concerted action of pneumonia. The other way to look at it is that if we do nothing about it, you're going to have 8.9 million children dying by 2030. So we are definitely going to be very far away from our sustainable development goals of reducing these causes of death. So if we do nothing about it, business as usual, we're going to have 3.2 million more deaths by 2030 due to pneumonia in children under the age of 5, and other deaths due to all these other conditions which are associated with pneumonia. So it is probably time to take action in order to reduce this burden. Is it really difficult to take action? Well, what efforts are there, or what methods are there? Nutritional intervention to reduce malnutrition. We know that breastfeeding is the best thing, and we should always encourage the patients to breastfeed their kids. Newborn care is very important, including proper care of premature babies. Availability of antibiotics and using antibiotics when the pneumonia is not severe is important. And obviously, immunization. If we can prevent these diseases by immunizing the patients, we will definitely reduce the burden and reduce mortality. So, epidemiology studies are not lying. The highest cause of morbidity and mortality in under age of 5, and you can have very high mortalities and high case fatalities. The Dragonstein study shows that the pneumonia episodes of 0.51 episodes per infant year in the first year of life. And these studies were done by Heather Zahn in Cape Town and colleagues. So it looks like you're getting half an episode of pneumonia per infant in the first year of life, but you're getting an episode of pneumonia in a child in the first year of life. I mean, that says a lot. This cartoon really drives the point home about the deaths due to pneumonia in children under the age of 5. Globally, there's been 1,400 cases per 100,000 by the time this was done. And most deaths were happening in South of Asia and West and Central Africa. There were about 800,000 deaths. These deaths were even more than the diarrheal deaths and malaria deaths. So you can see that the countries that has got less than 5% of the deaths are Turkey, and then the countries that have got less than 10% of deaths include Brazil, Argentina, Mexico, and part of Russia, and Botswana. And other countries, 10%, South Africa, Southern Africa, part of Central Africa, and the higher percentage of more than 20% will be areas like Chad, and of course, areas like Afghanistan. And look at the areas, the first world countries, there's not even mention of the number of deaths that occur in these areas. So risk factors are kids less than 2 months of age, overcrowding, lack of breastfeeding, immunocompromised patients, both HIV positive and HIV exposed and uninfected. And the issues that we struggle with in Africa, which is biomass fuel, which Dr. Joseph clearly showed in his presentation, and environmental tobacco smoke. So we have pneumonia as a problem in the world, mainly in Africa. But 2020 presented a different animal called COVID-19. Now, COVID-19 has had a huge impact on children, that it really disrupted what was supposed to be helping to reduce the incidence of pneumonia, prevalence, and case fatality rates, such as immunization and antenatal care. So because of lockdown, all these services did not happen. And additionally, about 2 million under 5 deaths could occur in 12 months due to reduction of routine health services coverage, an increase in malnutrition, which is already a risk factor for pneumonia. So if you look at this cartoon and look at 2019 pre-COVID and 2020 with COVID, it's been reported that globally, the number of children living in monetary poor households could increase by 142 million, which is scary. As well, due to COVID-19 measures, approximately 80 million children under the age of 1 in at least 68 countries may miss out on receiving life-saving vaccines. And one of them are the vaccine that prevents pneumonia. Now, with everything happening, including COVID, when a patient presents to you, and this cartoon clearly describes that with an arrow on the head, you start thinking, maybe I should run a COVID test for you because it's more common, instead of more prevalent now, instead of looking at what is looking at you. So WHO has revised the definition of pneumonia. Long time ago, it used to be non-pneumonia, pneumonia, severe pneumonia, and very severe pneumonia. But now they've been revised into non-pneumonia, which usually suggests that the patient has got upper respiratory tract infection, with pneumonia suggesting lower respiratory tract infection. So children under the age of 2 months of age will have severe pneumonia. And this will actually assist in not wasting time and acting quickly and intervening quickly and looking for danger sign and intervening rapidly. Children with 2 to 12 months of age and 1 to 5 years of age, either they've got pneumonia or severe pneumonia. If they've got pneumonia, which means they've got cough, chest indrawings, and tachypnea, if they are stable, they can be treated as outpatients. If they are sick, they get admitted. But if they have malnutrition or HIV infected, we classify them as severe pneumonia in order to speed up the intervention. And so is the patients who are 1 to 5 years of age. So this classification is supposed to make life easy for the clinician to act quickly and rapidly in trying to help the child. With data coming out, we obviously have to use level of evidence in trying to justify what we're doing. So one of the things that is important is looking at the level of care, level of evidence. And with level of evidence, one being based on randomized controlled trial, which is solid evidence, And as you go down to 5, the level of evidence becomes weaker until you get to level 5 with expert opinion without explicit critical appraisal. And these are when the professor tells you, in my opinion, it's a level 5 evidence, people. So it tells us that for you to make this diagnosis of pneumonia, you need ears, stethoscope, and most importantly, what's between the ear and the stethoscope. That's your brain. So pneumonia, by and large, in children is a clinical diagnosis. When patient presents with cough, difficulty in breathing, or fast breathing, you have to examine the child to look for signs of malnutrition and signs of immunocompromise. Look at the respiratory rate, work of breathing. One of the tool that has come up to be very useful is actually pulse oximetry, because if the patient has got low saturations, they are likely to be telling you that they've got more severe disease, and those patients need to be admitted. But if they pay in the work of breathing, and the level of evidence there is very high, it's 1A. And then most patients with pneumonia, and they don't have any low saturations, and they're drinking and comfortable, and they're over the age of 2 months, they can be managed safely as outpatients. What about radiology? You saw the presentation by the adult professor to say that radiology is helpful. In children, it's a little bit of a different story. We know that radiology cannot discriminate between viral and bacterial pneumonia. So chest X-ray can be done, but it's usually reserved for looking at complications rather than diagnosing the disease. Ultrasound is coming up as one of the tools that you can use for pneumonia. The problem with ultrasound is obviously the expertise, and the advantage of it being that there's no radiation. But chest X-ray, unfortunately, still remains the standard investigation. A CT scan cannot be used as a diagnosis initially unless you're dealing with complicated pneumonia, including you're dealing with bronchiectasis. But with bronchiectasis in children, you're obviously going to do a clinical assessment first before you do a chest X-ray and a CT scan. So when can you really do a chest X-ray in children? If your children have got severe pneumonia, because there might be just severe pneumonia and complications, when you suspect pulmonary tuberculosis, and when you suspect that the patient has got foreign body aspiration, or the patient has got pneumonia but is not getting better, because could it be something else? Could it be a foreign body? Could it be a pulmonary tuberculosis, which actually goes back to the indications above. And if the child is under the age of 5 and has got fever and leukocytosis, you might consider doing a chest X-ray. When you do a follow-up X-ray, so in adults, you have to do a follow-up X-ray much quicker. With children, only indicated within about 2 to 4 weeks if you've had a lobar collapse, because that lobar collapse might be hiding a foreign body underneath. Document resolution of a round pneumonia, because you might be hiding a gone focus, which suggests TB underneath. And then if you think that the child has got effusion, a chest ultrasound is a better modality to use than a chest X-ray. Now, this child, this photograph is courtesy of Professor Masekela, my colleague. This child presented to Professor Masekela's unit with signs of pneumonia, and obviously there's an endotracheal tube there. He was intubated because the child was sick, had to be ventilated. And if you look at the X-ray, you can see that it shows diffuse patchy opacifications, which could be in anything. It could be staph pneumonia, it could be pneumocystis jirovecii, it could be TB. And when they did the gene expert, they found the child was positive for TB. So, and this tells you that children can actually present with acute pneumonia, and the pathogen can be tuberculosis, Mycobacterium tuberculosis. This X-ray is courtesy of my the colleague who's a pediatric surgeon. This child is presented with cough 3-month-old presented with cough and was suspected to be having bronchiolitis. The child had normal saturations. The child was playing around, but the child had some few sounds on the left side of the chest. And the radiologists thought this child could be having a cyst or something like that. But if you look at this X-ray properly, you can see that the left hemidiaphragm is elevated. Left hemidiaphragm is elevated, and you can't really see part of the diaphragm. And you can see that this is bowel. So this child has got a left diaphragmatic hernia. And if the clinician could have put the stethoscope a little bit longer there and trying to differentiate between what sounds they're hearing, they would have heard bowel sounds and probably would have made a better diagnosis than. So this chest X-ray was incidental. In normal settings, that child presenting that way would not have a chest X-ray done. But if you're a astute clinician and you're gonna examine patients properly, you probably would suspect that there is something going on. This child presented at 21:55 p.m. at night it's a child 3-year-old who was running around and started coughing, and the parents were concerned. They rushed the child to emergency room, emergency department, and after the clinician took history, suspected that something is not right. The child was not coughing, and suddenly the child is coughing. And then on further assessment, they found that the child's X-ray showed the right side was hyperinflated, but you can't see really anything there. And there's also unilateral wheeze, which obviously led the doctor to suspect that there must be something going on. The child was well, coughing now, suddenly he's coughing and has a unilateral wheeze. Therefore, in pediatrics, the 3-year-old foreign body. So they sent the child to me, and we never even did any other X-ray. Took the child straight to theater, and we found a pit in the airway. And you can see the follow-up X-ray showed a resolution of that, because that was just the bowel valve effect from the foreign body. So if we look at laboratory diagnosis, there are a lot of things that you can throw around. We can do the C-reactive protein, ESR, white cell count, but unfortunately these don't differentiate between viral and bacterial pneumonia. If the CRP or C-reactive protein is more than 40 milligrams per liter, and radiological confirmation can suggest bacterial pneumonia. One important test to do always in our setting in Africa, in sub-Saharan Africa especially, is to do an HIV on the kids, because you can do something about it. Microbiology and blood, pleural effusion, pleural fluid can be done, should be reserved for patients with severe disease. What about PCRs? Now COVID, SARS-CoV-2 PCR should be done in children with pneumonia being admitted. And what about the nasal viral PCRs? These are usually maybe useful for viruses like respiratory syncytial virus, RSV, influenza and para-influenza. But they've got a side effect, which I'll discuss later. Blood cultures are helpful, but they have low diagnostic yield. If they are positive, they can actually help with deciding which antibiotic to use. Sputum is always helpful, especially for Mycobacterium tuberculosis, Pneumocystis jirovecii, and pertussis. Tracheal aspirates and percutaneous lung aspirates give you better representative sample, but they need expertise. These are reserved usually for pulmonologists. If you've got a pulmonologist in your center, we can go and do a bronchoscopy and do a bronchoalveolar lavage. So it's not a test that you're gonna commonly do. And if you're gonna do a tracheal aspirate, so you have to be careful that you don't injure the trachea. If you suspect CMV, you can do CMV viral load, and urine antigen testing has got poor specificity due to nasopharyngeal carriage in children. So Heather Zai has done good studies with a colleague in the Dragon State Child trial, the PETCH trials. What we're seeing now with the use of vaccines is that the organisms are changing. So the common organisms used to be strep pneumococcus or strep pneumonia and strep Haemophilus influenza. But now we're seeing that with that, the organisms, we're seeing a little bit more of non-typable Haemophilus influenza and Staph aureus as a cause of severe pneumonia in children in South Africa. And pertussis, we're seeing pertussis in young infants who are unimmunized. In Cape Town, the PERCH study as well. Patients hospitalized with pneumonia, 16% of children living with HIV, 11% of children who are HIV exposed and infected, and 5% of HIV unexposed children. And generally, pertussis is around. So, like I said, this is with courtesy of Heather's Eye as well, that we are seeing that we're not getting clear-cut pneumococcus, culturing pneumococcus as much as we used to do. And I think probably due to improved diagnostics, we've got better vaccines now, and we are seeing a mixed picture of infection of both bacteria and viruses, and pertussis and tuberculosis are still around. So this clearly shows in the PETCH study that patients, 43 to 85% of children with culture-confirmed tuberculosis presented with acute cough. And that's really clearly describes the first chest X-ray that we showed with the patient coming with acute pneumonia, and we culturing TB, getting TB from T-Nexpert. Now, this is the thorny part of medical education, that we have been taught everything. Our professors and doctors have taught us very well, but one thing they've never really taught us is costs. And this is an example from my kind of settings of what it will cost to do these investigations. These are at private rates. That's private rates, fee for service. In your settings, you obviously get subsidized by government and other agencies, but it doesn't take away the fact that these are the real costs of this investigation. So if you are a medical officer or a doctor or your consultant asks you to do an area of investigations, think about how much it's going to cost. HIV, an average of $14, G-Expert, about $80 on average, COVID, $55 on average, pneumocystis jirovecii about $92 on average. So the newer the test, look at the multiplex PCR. So this has been a problem in our setting where the private medical aids or private healthcare funders had really been up in arms on our private doctors for indiscriminately doing multiplex PCR, especially in outpatients. So this is actually a very important lesson, I think, to all of us to think about costs when we're seeing patients. The studies have been done on costs, and it's clear that, and this is based on the old criteria of classification of pneumonia, that in high-income countries, cost tends to be a little bit higher than in middle-income countries, and the more severe the patient is, the higher the cost. We also did a study that is actually part of the systematic analysis in Pretoria, where we actually found the same, and patients who are HIV positive had higher cost than patients who are HIV negative. And because they are sicker, and they did a little bit more investigations than patients who are HIV uninfected. So in summary, patients who are 2 months and older with clinical pneumonia and normal saturations can really be managed as outpatient without doing a single investigation. Use a stethoscope, use your ears, and use your clinical acumen. A child who's 2 months and older with pneumonia and has got malnutrition or immunocompromised, has severe pneumonia and needs to be admitted, and or special attention be taken into the child, otherwise it's going to be a mortality. A child less than 2 months of age with pneumonia has severe pneumonia and needs to be admitted in further investigation. And investigation should really be left to patients who are admitted to the hospital. What have we learned? We know that we've got a beautiful WHO classification, revised definition of pneumonia, which assists us in clinical care. A pulse oximetry is a very useful measure, and it can help us deciding the severity of the pneumonia, and the level of evidence is very high. Chest X-ray must not really be routinely done. It must rather be left for complications. Ultrasound can be useful in safe hands. And if you think about which laboratory test to do, think of obviously COVID tests, gene expert for TB, HIV test, and blood culture, because they will help you in trying to know whether you're using the right antibiotics or not. And the CRP can be more useful together with a chest X-ray for bacterial pneumonia. And this obviously will be in patients who are admitted to the hospital. Tuberculosis can cause acute pneumonia, and we have to be aware of that and be on the lookout. And pertussis is important in unimmunized and incompletely immunized children. Blood cultures, low yield, but useful if pathogen is detected. And really, very important message for us is to say, a child dying every 39 seconds is not a statistic to be proud of. So if you have to spend money, maybe think about rather doing a blood culture, HIV, gene expert, and SARS-CoV test, but obviously the other tests will be guided by what you find clinically. Thank you. Merci beaucoup. I thank you.
Thank you very much, Nambona. That was excellent. Big presentation on a small people subject. And now we go to the most important speaker of the day, Dr. Kiplagat Sige, who is actually the main promoter of this particular meeting. He's a clinician, he's a medical doctor, he's a scientist, he's a researcher, he's a public health master. He is the medical affairs manager for Anglophone Africa at Biomex. His clinical diagnostic portfolio includes East, West, and Southern Africa. So he's really covering the whole of Africa, and he's going to talk about how syndromic testing is transforming the diagnosis of respiratory infection, which should be very interesting to most of us. So over to you, Dr. Kiplagat Sige.
Thank you very much, Prof. Alwatch, and also thank you very much to Dr. Molemo and Dr. Bertrand, who came before me. Their excellent background to the topic of the day, touching mainly on pneumonia, but obviously on respiratory infections in general. So I'll go straight to my presentation, which is focused on how syndromic testing is transforming the diagnosis of respiratory infections. I know the two speakers have shared their insights for both adults and pediatrics on the challenges that we face in managing these conditions. And I know diagnostic is not the only issue that is faced in trying to curb the morbidity and mortality, but it is one of the areas that we can see where we are in terms of the latest innovations. So that's a brief in terms of how the presentation will proceed. So for those who might be hearing about the company for the first time, bioMérieux is a diagnostic company whose focus is to improve public health, especially in the fight against infectious diseases. And our lines of diagnostics are mainly in microbiology, molecular biology, and immunology, or immunoassay. And obviously this year, we've had one of the greatest health challenges in our lifetime, an unprecedented pandemic. And just to show the kind of solutions bioMérieux has to cover COVID-19, both from a diagnostic perspective, but also in terms of monitoring of the complications and in holistic patient management. Obviously, PCR has been the most important diagnostic tool that we've discussed in 2020 for SARS-CoV-2. But also we have serology, which is important from an antibody detection perspective for SARS-CoV-2, but also for other elements of immunoassay, such as the cardiac markers, coagulation profile, and PCT, which has been discussed by the previous speakers. And also looking at other tests, such as the blood culture, which has been also mentioned as a critical tool in monitoring the patient in front of you with COVID-19. So diagnostics are part of the puzzle in trying to manage patients with various infectious diseases. And this slide, basically, I took it from Rosanna Pilling, shows how it is playing a critical role across the patient journey, from incubation when you're trying to screen for potential infections or other conditions. Of course, when the patient presents with symptoms, you want to confirm a diagnosis by ruling in and ruling out. And then as you proceed to treatment, can be used to monitor the various treatments. So it is estimated that over 70% of clinical decisions really do rely on test results and recommendations. But obviously this must be done in conjunction with the clinical evaluation, as well as other factors specific to that situation or specific setting. So just to show how far we've come in terms of the history of diagnostic modalities, particularly looking at infectious disease. And over 150 years ago, culture was invented, and it continues to be the mainstay of diagnostics, particularly in infectious diseases. But over the last 30, 40 years, we've had a lot of change, moving towards point of care antigen tests, but also the PCR. I know the gene expert was mentioned, but there are also now multiplex PCR panels which can be used to detect multiple pathogens simultaneously. And just trying to show that culture, as was mentioned by one of the speakers, doesn't have a high yield in many cases. And so the culture independent diagnostic tests also have a role to play, especially in a more rapid and more broader collection of data. So traditionally in infectious diseases, what we do when a patient presents with an infectious disease syndrome is that the physician or the clinician will suspect a list of pathogens, maybe based on the local epidemiology or based on other factors. And usually we, depending on how sick the patient is, you will start empiric therapy, but at the same time, ideally you should be taking 1 or 2 tests to confirm the etiology. But if the test comes back negative, then you're forced to revise the thinking and repeat the process all over again, and perhaps guess another list of tests. This can go on and on. So with traditional testing for infectious disease, what is seen is that you may have one sample or multiple samples, depending on the condition, where you do multiple tests, and depending on the test, the results may take hours or even days. And this comes back with individual reports, and obviously this can lead to increased length of stay or even length of period without decision as to what is happening to the patient. So with syndromic testing, we look at syndromes. And basically a syndrome we know is a group of symptoms that together characterize a specific disease or disorder. So it's a symptom-driven approach where one rapid test looks for multiple targets or multiple potential pathogens. And this then maximizes the chance of getting the right answer, hopefully in a clinical relevant time frame. And so when the patient presents in front of the clinician or the physician, you go for one test that looks at multiple pathogens. And once you get the positive pathogen or etiology, you then start targeted treatment. So syndromic testing is trying to simplify what has historically been quite a challenge of doing multiple tests, and also not just to pick multiple targets, but also it does it in a quite a in a very short time frame of about an hour, which can be quite clinically relevant, especially when you're talking about critical care. So with the solution that we have at bioMérieux, it's called the BioFire. What they've done, and for those who are familiar with PCR, you know very well that PCR has several stages, from preparing the sample to extraction of the nucleic acid material to amplification to detection. And depending on the lab, usually this is quite a laborious, multi-stage process, usually involving even multiple rooms. And this can take a very long time, and it requires a lot of training. And basically, beyond 7 targets, it's unlikely to capture more than that in one run. So with the BioFire, we've integrated all these steps into one closed system that makes it possible then in an hour, you're able to then get not just multiple targets, but your simplified testing regime, which is a bit easier to run. So currently we have these 5 panels available across most markets that have this solution, including in Africa. We have quite a number of facilities that are using. So you have your respiratory panel, 23 targets, blood culture identification panel, 43 targets, the GI panel with 22, meningitis encephalitis panel with 14, and pneumonia panel with 34 targets. And it's important to note that the respiratory panel was updated this year to include SARS-CoV-2, obviously, so that it can include that in a report. So obviously for today, the main focus will be on the respiratory panel and the pneumonia panel. It's just important to see that this is a solution that is really broad and can cover several areas of clinical interest. And again, in the hopefully not too far distant future, we have other panels that are being developed, such as the immune profiling panel, which tries to look at immune status of critically ill patients by looking at about 16 biomarkers, which would be of relevance to make a clinical decision. So in terms of the respiratory panel, we start with the current one, which is 2.1 plus. You have the nasopharyngeal swab in viral transport media, and you only need 0.3 milliliters of sample to get a report. The pneumonia panel, obviously you can have either the BAL-like sample or the sputum-like sample, depending on what is available or what is possible. And for this one, just 0.2 ml of sample is enough to get a report. So these are the targets available on the respiratory panel, predominantly viruses, because it's looking at the upper respiratory tract. It can also present as a bit of a surrogate to lower respiratory tract colonization. And bacteria, just the 4 main bacteria which would be relevant for upper respiratory tract infections. And in about 45 minutes, you're able to get a result. It's actually the shortest running panel currently. And in terms of benefits, I'm just going to present a little bit of clinical data that is relevant. There's a lot of studies which I can share actually, but just the focused ones relevant for today. So in terms of the duration of IV antibiotics, there was a study that showed you have a reduction of about a day if you go for the panel compared to routine testing. If you look at length of stay, it again reduced by about 1.1 days. If you look at the number of additional tests, such as chest radiographs, there was almost a 20% reduction for those where the panel was used. And again, despite the fact that it is a PCR-based technology, and it definitely will not be as cheap as other diagnostic tests, as has been highlighted by Dr. Kitchen, it's important to look at it from a holistic perspective also, where in some of the studies they showed significant cost savings for ICU patients, whether positive or negative. And this was mainly linked to obviously length of stay and length of additional tests and treatment. So it may not be the cheapest test on the market, but holistically it has some downstream cost benefits. And for the RP 2.1 plus, we also have this feature called the syndromic trends. And this works in a country where that has at least 3 systems active. So the data is able to be this platform is able to be opened up for that country, so that all the facilities that have the system are able to see the kind of trends, epidemiological trends for respiratory viruses in that country. So this is a snapshot from one of the trends, probably from another part of the world. But you can see it shows the kind of pathogens that were circulating. And I think one of the things that was shown is that, if you look here at 2020, obviously due to COVID-19, all the pathogens dropped, interestingly, obviously because of, the sanitation measures and SARS-CoV-2 taking over and the focus being on that. So it's an interesting feature which I think is useful, not just for clinical care, but also for research in terms of understanding the kind of trends in a particular country. Moving on to the pneumonia panel. Again, this one having an array of pathogens, predominantly bacterial, obviously as expected, because we're looking at lower respiratory tract infections. The bacteria, they're the 15 common bacteria, which are, the result comes out as semi-quantitative, with Bean's result, which is basically the 1 log rounding off. We also have some atypical bacteria captured, which are qualitative. And then we have viruses, which are essentially the same as RP2 plus panel. We also have antibiotic-resistant genes that are captured as part of the targets, but it's only reported if the microorganism, first of all, is detected, the microorganism that will contain, that would potentially contain the resistant genes. And also it cannot be a definitive link to resistance. It is just given as a detection of the gene, and clinical interpretation is necessary. In terms of looking at the log semi-quantitative data for the typical bacteria, again, there's an interpretation that has to be followed. This slide is based on some practice from the medical clinical microbiology textbook that basically looks at, depending on the specimen, you also have to correlate with the gram stain, with the culture, especially the quantitative culture, and the neutrophil count, so that you make an interpretation of the semi-quantitative bacterial result. And again, this can vary from country, region, laboratory, but just shows that it can be used to make some clinical decisions. Again, for the pneumonia panel, it's very important to look at the sample type, as well as the local practice. If we go for the non-invasive sampling, such as your sputum or endotracheal aspirate, they tend to be easier to get, but they're prone to give you colonizing bacteria from the upper airways. Invasive sampling would then require intubation, but it's more likely to give you only pathogenic bacteria from deep within the lung. And again, obviously these sample types depend on the type of disease. Will tend to go more invasive if it's ventilator-associated pneumonia and potentially hospital-acquired pneumonia. But for community-acquired pneumonia, we tend to go for the sputum. So whatever the result comes out, it's good to correlate with the presentation, the kind of sampling that was done, so that you make a decision, not just based on the result, but the holistic understanding of the information in front of you. So the key highlights of the pneumonia panel as I come towards the close of my presentation. First and foremost, it helps you detect significantly more pathogens, particularly for pneumonia patients, compared to culture and standard of care. And it obviously significantly reduces time to pathogen identification. Remember, we talked about 75 minutes, which is quite short compared to some of the other tests. Again, antibiotic therapy, very important in optimization and also reducing unnecessary use of broad spectrum antibiotics. And again, this can be looked at also from a cost-saving perspective, and obviously from an antimicrobial stewardship perspective. And then additionally, of course, reducing length of stay, both in critical care and also in general in the hospital. And obviously, it's currently being evaluated in several trials to further look at these benefits so that it can better inform how best to use it. If we look at it from a COVID-19 perspective, because the pneumonia panel doesn't have SARS-CoV-2, unlike the RP panel, which does. However, it did play a role in several studies, as highlighted on this slide. First of all, depending on the length of stay, it was able to identify a different set of bacteria in specific patients. In certain cases, no viral co-infection was detected. It was also important in picking secondary bacterial pneumonia, which was a study in Asia, and also where empiric antibiotic therapy could then be justified, or the change of antibiotic treatment could then be effected. So basically, also in another study, antibiotic treatment was withheld until the pneumonia panel results were available in 28% of patients. So instead of going straight forward for empiric treatment, they waited for the results for these patients who had SARS-CoV, who are COVID-19 positive, and then were able to institute treatment based on those results. So in terms of take-home messages, first and foremost, syndromic testing we can see has superior benefits to traditional testing, especially in terms of time to result, as well as cost effectiveness over the long term. Syndromic testing can add valuable information. We've had we've had several cases of co-infections or underdiagnosed pathogens. Obviously, in a year like this, the focus is on COVID-19, SARS-CoV-2 detection, but there are patients who come and they have symptoms of what would appear to be COVID-19, but they are negative. So it will be important to find out what else they could be having as causing the disease. It continues to evolve, and the current panels will continue to be updated, and newer panels will also be launched. And these two panels specifically are supporting and complementing rapid diagnosis, especially during COVID-19 pandemic. Obviously, it is a complement. It is important to look at the clinical picture. It's important to look at other tests as well. And in many cases, when you need a rapid result, it's able to give very good information. And last, I think I've already mentioned about the complementation, but very important, it must be tailored to the local setting and health facility needs, as well as guidelines. It is a PCR-based solution, and it will likely not be available across all the main primary care facilities, but at least in the tertiary or second level, and particularly in critical care, it can make a big change in terms of people being able to get diagnosis faster and being able to make decisions even faster for the patients. And with that, I come to the end of my presentation. I'd like to thank you and hand over back to Professor Alwaj.
Thank you very much, Dr. Kiblagat. That is excellent. I've learned a lot tonight, and I knew I would learn something from you. I'm very impressed. A very good summary of this otherwise new approach to diagnosis of respiratory infection. There are not many questions, but maybe while you are still on the floor, as to say, just like to say, although you mentioned it, that may not be available at the point of care from primary care, but where is available? Is it easy to get personnel to use it? And is there any cost? Can you give us a rough idea of the cost affordability? Any good thing in our healthcare, we need to have the 3 A's. Must be affordable and acceptable and available for use.
Yes.
What are the practical implications? Because we know today we're confining ourselves to sub-Saharan Africa.
Okay, so thanks, Prof. I'll go straight into that question, and I like the fact that you talked of the 3 A's. So I'll try and use that to answer the question. So I'll start with Kenya, which is my home country. It is available, at least at the moment, in about 3 facilities, and it's a nice mix of private hospital, research facility, and public hospital. In terms of acceptability, you asked about ease of use. Typically, PCR is a complex process, the traditional PCR. With this one, everything is done within 2 to 3 minutes in terms of handling the sample, doing the test, and then waiting for the 1 hour for the run. So it is easier to train as opposed to the traditional PCR. And we've seen even locally, it has been adopted quite well. In terms of the pricing, it does obviously vary. But I think Dr. Kitchen did highlight some of the ranges of multiplex PCR. So it's not something that will be $1 or $5. It will definitely be at least around 100. But that again depends on your setting, depends on the various channels of delivery in the various countries. I know, for instance, Dr. Kitchen is in South Africa, and we do have a lot of it there, a lot more than in a place like Kenya. The northern countries, Egypt, Algeria, Tunisia, Morocco, do have a lot of it. Within the rest of Sub-Saharan Africa, a lot of it is in the research facilities, but there are few health facilities that are starting to at least try to use it for particular cases. So what we encourage even as a company is to start using it and see where it fits best in a diagnostic algorithm. It may not be used for, if 100 patients came today, it may not be used for all 100, but if you start with at least the first 5 or 10 and see the benefit, then over time it will be better to understand when to use it. I hope I answered it.
Thank you. Over the years, it's been customary just to do a lot of treatment of RTI on empiric, and it works so well because most of the basic tests we've been using over the years do not give you a positive result. So we've been able to use, based on our preliminary studies. Do you think this is going to add value to diagnostic acumen?
Yes, it would. I mean, we're talking about, first of all, increased positivity of results. Like you mentioned very well, a lot of tests have been giving either negative results or results that take too long. By the time they come back as positive, it's 4 or 5 days down the line. So in particular cases, some of the feedback we're getting, if I use the example of Kenya, is that in critical care, they're even talking of BioFire to the rescue as a sort of a tagline. So in particular cases, they look at a patient and they're not sure what's happening or they're very frustrated. They go straight for this kind of a tool because in 1 hour, maximum 75 minutes, you're able to then come up with a result and make a decision. I would have loved to, in fact, next time we'll have some of our clinicians who've had the experience to share some of the cases, actual cases that where they've used this tool to change the speed of diagnosis and also the care of the patient. So hopefully over time we'll get there.
Yeah, this is another comment from another participant. You more or less touched on it, but maybe just clarify further. Can syndromic testing replace completely the traditional biological diagnostics techniques for RTIs? If no, any limitations or complementary traditional techniques to it?
Yeah, so thank you for the question. I don't think we are at the point where we want to replace anything. This is a relatively new test that is slowly being evaluated, especially within the African context. In Europe and the US, they've had a lot more experience, and obviously maybe they are starting to replace some of the traditional techniques. I'll defer that to one of my colleagues who is in clinical practice, but basically the limitations obviously would be, being a PCR technology and the cost of the test, it may not be available to all facilities, but in specific facilities or in specific settings such as critical care, it can make it easier. Instead of people doing 5 tests and waiting for days or weeks, they can at least do a BioFire and in an hour know what is happening and how best to approach that patient. I don't know if Dr. Kitchen wants to comment.
Your presentation was the most interesting one, so I'll just have a few more questions for you. At the end of the day, these high-tech technologies do not identify the biological organism. They just probably mention some products or something related. What are the chances of false negatives or some false positives with some of these otherwise high-powered techniques.
Yes, you're right. In the sense that when you talk of the false positive, obviously, as you said, it is PCR, and PCR detects genetic material even if it's not viable. So sometimes you will get a result. So what we have in terms of, we have an instruction on how to interpret the results. And there are certain pathogens, if I can mention one like the herpes one, where there is guidance on how to interpret the result. So again, just like with any other test, it's not a matter of looking at the result and going straight to treat the patient. It's looking at the result and looking at the clinical context and trying to understand, okay, is this making sense? Should I treat or should I not? So yes, just like with any other PCR, there's that challenge of just detecting genetic material, but it's important then to correlate with the whole presentation.
Thank you. Maybe another comment for Dr. Kitchen. One participant asked that you talked about doing routine SARS-CoV tests in children, but he wonders that since SARS, at least he assumed that since SARS-CoV-2 is not a very common positive test in children, is it worth doing it as a routine?
Thank you very much for the question. But just before I answer the question, can I just add something onto the BioFire? I think one of the most important things about the tests is that we must try and avoid indiscriminate use, rather like focus on using it where you can, because you get the results very quickly, where it can help guide you in terms of what to treat and what not to treat. The problem, because of the cost, is that you're going to get into trouble if we just use it indiscriminately. And that's one thing that we should watch out for. Obviously, if the test is used more globally, the cost comes down and then funders become much more comfortable with using the test. Going back to the question of COVID, obviously, like I said in my presentation, that you cannot be doing investigations indiscriminately, and that includes the COVID test. So if patients come as an outpatient and they're obviously asymptomatic and they've got other problems, you don't necessarily need to do a COVID test. But if a patient is admitted and the patient is sick, it will be a good idea to know the COVID test, because some of these patients can present with a problem called pediatric inflammatory multisystem syndrome. And the presentation can vary. And these patients present like any other atypical patients with cough, fever, muscle pains. And if you know that it's COVID related, it will assist you in intervening quickly. And I know that it's not common, but there's a Cape Town study that has showed a series of about 23 patients. And in our health settings, we've seen quite a number of PIMS. They call it PIMS. So when you've got a test like that, I think COVID will help. The other place where COVID will be useful is that we know that we have a skills shortage in our settings. So if you have a COVID test, you can at least try and at least cohort patients and know that these patients are COVID positive and these ones are COVID negative, and it will actually help with delivering better quality of care instead of getting cross-infections and cross-contamination, especially among healthcare workers. And we know the healthcare workers are the people at risk, and if the healthcare worker is down, then you don't have anybody looking after the patients.
Thank you very much. Maybe back to Dr. Sigay. With this high tech, do you think that sooner or later you probably need just artificial intelligence to make a diagnosis once this thing is set up, rather than using human beings? In fact, I can see a good reason that the artificial intelligence is soon going to replace human beings, even in pediatric practice, in making diagnosis of respiratory tract infection.
Thank you very much, Prof. That's a tough one for me. Definitely AI is coming, not just in healthcare, in many facets of life. I'm not sure how it will go in terms of diagnostics, But definitely we are seeing more and more. If I can talk briefly about the immune profile panel, I know one of the things they're trying to do is to then have the 16 biomarkers put into an algorithm so that you're able to come up with a score. So in that score, you're able to then say this patient should be treated this way, or this one is treated in a different way. So probably from a data analysis perspective, to try and come up with, using AI to then mine the data. But I don't think I'm the best person to respond on AI. But definitely, let's just watch this space. We cannot forget our basic clinician acumen on how to, take the history, examine the patient, and do even some of the basic tests, and of course, examine the patient. But it's important then to look at where diagnostics is going. Like I mentioned, just over the last 30, 40 years, there's been this explosion of other diagnostic tools, including PCR. So it's important that we continue to look at the future as well as see what makes sense for a setting.
Okay, thank you very much. But I think that's the way to go. But anyway, medicine is advancing and diagnostics are even, medicine become a science rather than an art. So we have to be a bit scientific minded and assume that you don't always need those good old art medicine of examining the patient anymore. Now, Professor Bachu, do you have any comments or interventions?
Thank you, Joe. So I'm very impressed with the presentation on syndromic testing, and I think all my comment or questions have been taken in account. So I'm very excited to see coming this test in the clinical, in the daily clinical activities.
Thank you. Thank you very much. Let me just thank the speakers and the participants who have been with us in this interesting seminar, and thank Biomedics for bringing in this very up-to-date technology on diagnosis of RTIs. Thank Gombile for the organization of this webinar. And wish you good night and hand over to Dr. Sige to do the final comment.
Thank you so much, Prof. Thank you so much, Kobile. And of course, thank you to both Dr. Kitchen and Dr. Mbachu for the excellent presentations. I think before I make the concluding remarks, I've just spotted a question directed to bioMérieux. Somebody's asking, is there a possibility for bioMérieux to establish a checklist for the choice of syndromic testing so as to avoid indiscriminate testing? I think that was partly answered by myself as well as Dr. Kitchen. It is best for the clinical, it is best for each setting to make up their own algorithm on how best to use it. We've seen algorithms that have been developed in the US because that's probably the first country that used the BioFire, and they use it for specific cases. We've seen other algorithms in other countries. So it's best for the clinician team to make the algorithm, of course, in conjunction with other stakeholders in the hospital. It's usually not the place of the company to make that. However, we do have studies going on, both supported by bioMérieux and also funded by other partners to look at the best way to use the test. So I hope that answers that last question. So I think without further ado, I'd like to thank everyone who has joined this event this evening from the various countries. We appreciate your time. We appreciate your questions. We appreciate your engagement. And on behalf of bioMérieux, if you have any questions to either the speakers, you can direct them to the email that you used to register. But also for bioMérieux questions, you can seek your specific representatives in your countries or email me and we can respond to that. So I think with that, we've come to the end of the webinar, and I'd like to thank everyone and wish you all a wonderful evening. Thank you.
Thank you. Good night.
Good night.
Thank you. Good night.